very good morning, good afternoon, and good evening to all the delegates and the students in the field of hematology joining not only from India but across the world to the largest running webinar series in the field of hematology and maybe in across all the specialties. Welcome to yet another interesting webinar on 2025 EHA and Lugano Congress, the Soundbites, which is brought to you by Mumbai Hematology Group and ably supported by Intas Oncology. Today is Labh Pacham, a very auspicious day in India, wherein it's the one of the most auspicious day to start any new business or new venture or anything which you think is new in your life. And here we are continuously on the track of the webinar series. So this is the Labh Pacham for all the people in the field of hematology. And this benefit, the lab, is provided none other by Professor Dr. M.B. Agarwal sir since many years, since COVID times, and we owe a lot to Professor Dr. M.B. Agarwal sir for carving this webinar series for all the people across the globe. Thank you, sir. We thank Professor Dr. Amit Khurana for flawlessly executing all the webinar series. Uh, Dr. Amit Khurana needs no introduction. He is from Surat, but he is well known not only in India but across the globe. Dr. Amit Khurana, over to you, sir, for taking the proceedings forward.
Thank you, Mr. Ashish. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Vishal Jaikar from London, and he's going to lecture us on 2025 EHA and Lugano Congress Soundbites. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Intas, Roche, Unipath, Natco, and Lucian Life Sciences, and very well managed by Perfect Square. I thank Team Intas, Roche, Unipath, Natco, and Lucian, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Ankit Patel from Surat, our guest speaker for the day, Dr. Vishal Jaikar from London, UK, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 1st of November 2025, from 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time, we have Dr. Hani Al-Samkari from Boston, USA, speaking to us on chemotherapy-induced thrombocytopenia, new solutions for an old problem. And the following date, it is Sunday, 2nd of November 2025, from 11:30 a.m. Indian Standard Time, your Dr. Saikat Datta from Bhopal speaking to us on polatuzumab-based treatment of diffuse large B-cell lymphoma. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. They are very eminent hematologists, hemato-oncologists, all across the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. He is my mentor and very well known to me, Dr. Vishal Jaikar, who is MD, MRCP, FRC Path, Hematology, Consultant Hemato-Oncologist, King's College London, Kingston Hospital, Imperial College, London. After completing his medical education and postgraduate training in internal medicine from KEM Hospital, Mumbai, India, with 7 distinctions, he moved to UK, starting with hematology SHO job at University College London and Royal Marsden, whilst acquiring his MRCP qualification. He did his hematology specialist training at Imperial College NHS Trust London, Hammersmith St. Mary's and Royal Free Hospitals, and he has been a consultant hematologist at Kingston Hospital, London since 2011. He runs the very famous and very popular FRC Path Part 1 and Part 2 exam oriented courses. And I must tell you, must attend these courses. This is worth achieving, which are subsidized by hematology trainings from all over the UK, including delegates from UAE, Singapore, Hong Kong, India, and Sri Lanka. His main passion is education, integrated diagnostics, and immunotherapy. He has published in several peer reviewed journals, and he also co organizes the venerable Imperial Morphology courses with Professor Barbara Bain and is a senior lecturer academic contract at Imperial College London. He has conducted teaching workshops as invited speaker in Switzerland, Denmark, Norway, Oman, Kuwait, India, and Sri Lanka, and he has been appointed at King's College London since 2001 in an academic role as a lead for education and training in hematology, steering a preceptorship program for international faculty, including the popular CAR T cell motif, along with an eclectic program of courses, educational days, traineeships, and PG certs. Today, he's with us and is going to lecture us on 2025 EHA and Lugano Congress Soundbites. But before he does that, let me introduce our special guest and chief guest for the day. We have with us no other than Dr. Ankit Patel, medical oncologist from Surat. Let me introduce Dr. Ankit Patel to all of you. Dr. Ankit Patel is MD, DM in medical oncology, consultant medical oncologist and hemato-oncologist, founder of SOC, that is Surat Oncology Center, Surat. He is a Gujarat-based cancer specialist specializing in oncology and hemato-oncology. He has immense knowledge of treatments for all type of solid tumors and blood cancers in all age groups. He is also trained in bone marrow transplant. He is currently working at Lions Cancer Detection Center. He did his MBBS way back in 2008 from the most reputed BJ Medical College, Ahmedabad, and then he went to do his MD in general medicine from VS Hospital, Ahmedabad, and also obtained a super specialty DM degree in medical oncology and hematology from prestigious GCRI, that is Gujarat Cancer and Research Institute, Ahmedabad Civil Hospital. He has a rich experience in treating thousands of cancer patients at Ahmedabad Civil Hospital for more than 3.5 years. He is also a specialist in the field of chemotherapy, hormonal therapy, biological therapy, and palliative care in all types of solid tumors and blood cancers. It's my privilege to welcome Dr. Ankit Patel to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Ankit Patel.
Thank you, Dr. Amit, my colleague. Uh, Everyone should know we had started practice in Surat at a similar time before 1 decade. So he's my colleague and my well-wisher. Today I will give some data regarding the future of oncology and hemato-oncology and what are the brightness you what are you have chosen a very good career by some economics and statistics. As we know, in India is now in future a cancer hub. Today, according to statistics, we have around 2,000 medical oncologists practicing in India and around 700 hematologists who are practicing in India for 15 lakh new cases per year. The cancer incidence increases around 10% every year. Every year. So projection is around we have double the cases in next decade. But number of the doctor will double after 10 years. So the opportunity for the medical oncology, hematology is very huge in India. In India, only 55 to 60% of the total cancer patients are assessing the regular standard care. Rest of the patients are not going for the regular care because of a many factor, because of lack of infrastructure, lack of the doctors, lack of the infrastructure in third tier cities. But there are many steps taken by the government by increasing the seat, increasing the DNB courses. So ultimately, we will get a new doctor. We get a double our doctor strength in next 10 years. Now, financial part, India is a 40,000 crore market in oncology. It increasing around 80% as a CAGR every year. And average cost of chemotherapy in India is 18,000. If we consider all the group, and average burden of oncologists is around 7,700 new cases per year among the oncologists. So you have a very good opportunity and for serving a society and also having a good opportunity to earn more. So best of luck to my all hematologist colleagues to choosing the bright future. Now over to you, Dr. Khurana.
Thank you, Dr. Ankit, for that wonderful words of wisdom and bringing out the real statistics of real India in the market today. Thank you so much, Dr. Ankit Patel. And now, sir,
Thank you.
Dr. Vishal, sir, the screen is yours. Please share your screen and please proceed. Thank you so much.
Okay, Amit, you can see my slides okay?
Yes, sir. Perfect.
Perfect. Okay, so I love that this is turned global. I mean, I did this, I think I've done it a couple of times. This is my third time. And people who have probably attended this webinar have seen the same slide. Like Amit kind of, you can see the color vanishing off his face when he sees the same slide again. But I love it because it actually tells you, at least from my perspective, that this is really Dickinsonian, by which I mean you're trying to blend the so-called high tea that is done amongst the elite in London, very nicely blending with the kata chai that you get in Mumbai. So I think it's a good thing to combine the so-called chaos. I mean, when I say chaos, I mean it in a good way. The choreographed clinical translational research and basic research chaos that we have got across the two capitals. And I think times have changed. I think when I moved to London, which was around 20, 22 years ago, Mumbai was always deemed to be the slumdog millionaire capital, resource poor, resource constrained, and London was very Victorian and resource rich. Resource replete, but I think it's changed now. There's a lot of equity between the two capitals, and Mumbai. I'm very proud to say because I'm a Mumbaiker originally from Villapale. So it's probably I don't know how the race is going to unfold, but it looks very much like the tables have turned, and Mumbai seems to be more resource rich, and London seems to be struggling. And I loved what Ankit said. I mean, I'm not very good at Hindi, but I love the fact that all of you there are trying to blend Lourdes Saraswati and Lourdes Lakshmi together. And that kind of nicely and gently gets on to my next slide, which is about Diwali, wishing all of you a belated happy Diwali. And I had no idea that it was an auspicious day. My mother-in-law told me that Akshaya Tritiya was the only auspicious day, and therefore I had to get engaged and married in a span of a year's time, always on Akshaya Tritiya. But hey ho, it's been 23 years and we are going, so must be something happy and auspicious about both days. Anyway, so today what we're going to do, I think I've got around 40 minutes or thereabouts to try and curate what I think might be horizon scanning. And I think Ankit's very nicely put it. I think hematology is at the vanguard of innovation. Every time you go to ASH, every time you go to EHA, you go to Lugano, you go to ISTH, you always feel like a tectonic shift has happened. There are huge paradigm shifts. And I think what I personally love about hematology philosophically is that you get to be very geeky and nerdy, like Sheldon. For people who watch Big Bang Theory, we are absolute fans. But you can get that Sheldonian geekiness from the bench to the bedside very quickly. So all the research that happens in hematology, or a lot of it that happens at the bedside, is not just esoteric. It is not an expenditure of word beyond the income of ideas. The ideas do get fructified. You discover JAK2 in 2008, and you've got a JAK2 inhibitor in a phase 2 trial in 2010, right? So I think everything seems to be actionable, and that is what makes hematology quite enticing, particularly because I'm picking up that there might be quite a few trainees and impressionable minds. So what we're going to do today is we're not strictly going to stick to the two congresses, which what the title says, but we're going to go through a few recent advances from various venerable congresses, including ISTH. And I wanted to keep it at a good bandwidth, by which I mean that not only are we going to talk about malignant hematology, but we will also go through some important excerpts from non-malignant hematology. So these are my curated headlines from the congresses. And the whole idea is that you try and get to your version 7.0. And in hematology, it's not just moving to iPhone 16 or 17 or whatever the version is, but hopefully very soon getting 3D holograms out of that hematology iPhone. It's just kind of telling you how quickly the branch moves, and everything is quite tectonic. So the first thing, trying to stick to EHA and to Lugano and to ASH, we're going to go through a few quick headlines in mantle cell lymphoma. And then we will move swiftly on to non-malignant hematology. I'll be talking about a promising reversal agent, followed by a couple of recent trials presented at ISTH on DOACs. And then we will gently slide back into malignancy with myeloma. So mantle cell lymphoma was an essay question in our exam last time. And the reason why everyone's talking about mantle cell lymphoma is that the paradigm seems to be shifting very quickly. So let's talk about first-line recent advances. Some of them are 2 years old, but I'm just going to get everybody on the same page. So the big thing that is happening, as many of you might know in mantle cell lymphoma, is that autologous stem cell transplant might be in RIP mode, having an existential crisis. So you should all know that if you are young and fit, the standard of care for mantle cell lymphoma is chemoimmunotherapy, followed by autologous stem cell transplant, followed by maintenance, typically with rituximab for a period of 2 to 3 years, depending on where you practice. And the idea here is that can we challenge that position of autologous stem cell transplant? So we are quickly going to go through 2 important seminal trials which are pushing autologous stem cell transplant in the so-called junk folder. So this is how I look at mantle cell lymphoma in my headspace for first line. Are you fit for transplant or are you not fit for transplant? So we're going to talk about the Tom Cruise trials. So the 2 trials that I will be talking about for fit patients where ASCT is an existential crisis are going to be the Triangle and the ECOG ADN 4151. So those are the 2 trials. So these are the standard recommendations, and I've just copied and pasted them from the British Society of Hematology, which are easily and freely available on the net. But I think induction chemotherapy is what you're using, followed by ASCT. This is our favorite go-to induction chemotherapy in the whole of England, probably even in Ireland. So we tend to use the Nordic protocol for the fit Tom Cruise patients, which is an alternating kind of schedule where you do maxi R-CHOP and high-dose cytarabine. So the horizon scanning on this is as follows. So Triangle study presented 3-4 years ago in ASH, and more recently again in ASH 2024 and EHA, because they were talking about overall survival and not just failure freedom survival. So this is the Triangle study presented by Martin Drayling. And I can tell you that Martin Drayling is very popular. He's a very eloquent speaker. Every time he comes on the podium, you can hear cheering from people in the front stalls. So he's very good at lobbying. All the Germans are sitting in the front stalls when he's up on the stage, and you can hear loud cheers. But I think that's very endearing. Anyway, so for people who are not familiar with the Triangle study, these are the 3 arms of the Triangle study. Let me try and see whether I can get my laser pointer. Yeah, I think I'm in business. Okay, so the standard of care is here. The standard of care in this particular trial for induction regimen is alternating cycles of R-CHOP and R-DHAP. This is not something that we use in UK. As I alluded to, we probably use, or not probably, we do use the Nordic protocol, followed by stem cell transplantation. It says observation here because the rituximab maintenance thing happened midway through the trial. So when rituximab maintenance became a standard of care, people in this trial also started getting rituximab. So almost half or upwards of half people did get rituximab in that maintenance arm. And these 2 are the experimental arms. So here is an arm. In both these arms, what you can see in common, where my laser pointer is the ibrutinib. So you're introducing a BTK inhibitor, and you're sprinkling that on the backbone of your induction, and you're also sprinkling that on the backbone of your maintenance. So people who did get rituximab maintenance also got ibrutinib in that maintenance cohort. And I think the tantalizing question here is that if I use ibrutinib in my induction, as you can see here, and my maintenance, can I do away with autologous stem cell transplant? So all of you really now need to focus, particularly trainees, on the difference between the so-called freedom from failure and overall survival between this arm, which I'm going to call arm B, and this arm, which is arm C, because they are identical with ibrutinib embedded with R-CHOP. You can't really put ibrutinib with RDHAP because of the drug interaction. So you can only use it with R-CHOP. And we're going to try and understand whether ASCT can be blind spotted. So these are the two arms where we are looking at. So these are the initial presentations which came out 3-4 years ago. And this is freedom from failure survival. And what I want you to focus on is that, yes, if you do not give ibrutinib to patients, your Kaplan-Meier here looks very saggy. But that tantalizing question that you're asking, is transplant making a difference? You can tell that I am struggling to put my laser pointer between these two Kaplan-Meier curves, telling you that they are overlapping, they are smooching, there is no statistical difference between the two. So this is perhaps telling you that once you start using ibrutinib, what is the utility of putting somebody through an autologous stem cell transplant? And the study was represented in 2024 December, which was only 11 months ago. And again, you can see that at the end of 4 years, the laser pointer still doesn't really get between the two curves. This is important because that is what was presented as a big headline in ASH of last year. This is when all the people annoyingly get their iPhones and go click, 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 and flash, flash, flash. And I mean, I find it extremely vexing. I mean, all the slides in ASH are made available to you if you're a member and you're attending the Congress. I mean, what is the point of photographing them? Anyway, I shall keep my 49-year-old cantankerous behavior aside and continue with this. Again, the take-home message is there is no difference in overall survival. So once you use ibrutinib in both the arms, induction and maintenance, perhaps autologous stem cell transplant becomes redundant. However, if you look at the granularity of the data, I just want you to be aware that if you've got patients who have got high-risk mantle cell lymphoma, and that basically means a high MIPI-C score, pleomorphic variants, blastoid variants, I don't think all of them were bundled up, but if you look at the Ki-67, which is an important biomarker of aggression in mantle cell lymphoma, feeds heavily in your prognostic scoring system of MIPI B and C, you can see that the curves do separate out in patients who have got a Ki-67 upwards of 50%. So the take, I mean, though this is not, I mean, there are not enough numbers for it to be statistically powered, but I think there is a signal saying that if I've got a patient who has got a really high Ki-67, maybe that patient should go through a transplant, unlike what this trial tells you. So in our MDTs, I mean, we do not have license for R-CHOP and DHAP, so we can't use the triangle protocol in UK. We have used it in a couple of our private patients. But even in that particular clientele, if you're going to use the triangle protocol and kind of, you're going to say, no autologous transplant, I'm going to induct you and then just put you on maintenance without the ASCT, if you've got a high-risk patient, our MDT will still show a favorable incline towards using autologous stem cell transplant. So in this particular patient population, maybe it's not in RIP mode. So that's an important thought to take home. So the triangle study is pushing down the autologous stem cell transplant. It goes on. And I think this was very interesting to me because British Society of Hematology is a conservative society. It gives you comprehensive guidelines, but when it makes recommendation, it is very guarded. And it will make recommendations for drugs and regimens which are funded by NICE, which is the approving body in UK. Everything that happens in America takes 18 to 24 months to get approved in UK because, as some of you might know, we have a different system. Unlike the Americans, the depth of the pocket doesn't determine the success of or the quality of clinical care. We believe that we live in an egalitarian society, so we believe that everybody should have a good equity with our sustainable resources. But what you can see here, if I can get the arrow, yeah, you can see that this is the first time even the British Society of Hematology has made a recommendation that if you can get your hands on the triangle regimen, do not do an autologous stem cell transplant, okay, though it's not funded. So BSH, or British Society of Hematology, often makes recommendations for drugs which are approved by NICE, but this is one of those exceptions when it's making a recommendation on something which is not NICE approved. Now, that in itself is quite tectonic for me. Anyway, there are various other trials which are coming through, which are using a similar kind of platform, because people sitting there might be saying, why ibrutinib? Ibrutinib is like so 2012, 2009. Of course, I must be using Xanu or acalabrutinib. So here are some other trials which are also using zanubrutinib instead of ibrutinib. And again, there is no autologous stem cell transplant. But I think this trial is a phase 2 trial. We do not have it open at Imperial or King's, but other centers might be recruiting. This is the second trial, which is putting a nail in the coffin for autologous stem cell transplant. So this was a late-breaking abstract, again in ASH of 2024, and again got presented in EHA of 2025. This was presented by Timothy Fenske, who works at Wisconsin. So this is a complex schema, but what I'm going to do is, if you just listen to me, for people who are not familiar with the 4151I, here the important tantalizing question is, I don't care how you induct your fit Tom Cruise mantle cell lymphoma patient. You use DHAP, RCHOP, Nordic 2, whatever you're using. But if my patient goes into MRD negative remission, can I say that that's all very good and therefore I'm not going to do autologous stem cell transplant and I'm just going to continue with maintenance? So that is the basic question. So what we want you to focus on now are these two arms. Hopefully you can see my laser pointer is arms A and B. So this is the cohort of patients with mantle cell lymphoma, which is agnostic to the induction regimen, but they are in MRD negative remission. And the assay used here is an NGS-based assay. It's called clonoSEQ, and it takes the resolution of this MRD to 10 to the power of minus 6. And that might be a bit problematic, and we'll talk about it later, perhaps in the Q&A question and answer module. But if you can get your hands on an assay which puts mantle cell lymphoma patients into 10 to the power of minus 6 MRD negativity, the question is, should I do transplant and then 3 years of rituximab, or can I just take these people to rituximab? And very quickly, for sake of time, I'm not going to go through this. I'm just going to show you the curves. This trial was stopped in the interim because the futility was crossed and the results had to be presented in something which is as renowned as ASH. So here again, you can see that these are arms A and B. So these are all patients who have achieved MRD negativity. And once you start looking at their overall survival, there is no difference in arms A and B. They are smooching. I cannot put my laser pointer between those two curves, which is telling you that statistically this is insignificant, which means that if I get my patient into MRD 6 negativity, I don't need to do a transplant. I can just put rituximab maintenance, and there's no need to put the patient through the throes and travails and the toxicities of a transplant. Same is the case for progression-free survival. A and B keeps on overlapping. No difference whether you do transplant or not. And this is according to MIPI-C, and that too seems to be doing well. Unlike Triangle, where it says that your Ki-67 matters, here it doesn't matter what your Ki-67 is. If you can get your patient in a safe haven, in a happy Zen place, which is MRD negative 10 to the power of minus 6, no need for transplantation, is what this trial is telling you. So for sake of time, I'm not going to spend a lot of time. This was done during the COVID pandemic, so they're talking about that. Needless to say, if you don't do autologous stem cell transplant, quality of life is going to be better, morbidity is going to be better, mortality is going to be better, right? So these are the conclusions of that ECOG ARIN 4151 trial, and therefore people are talking a lot about ASCT should be or should be not for mantle cell lymphoma. Very quickly, in the last 2 or 3 minutes that we have got for mantle cell lymphoma, we will talk about patients who are unfit and the 2 trials that I wanted to bring to your attention, and we will swiftly go through those trials because I'm just going to give you the headlines and then you can mull, chew, and reflect on them. So the ECHO and the ENRICH trials are the 2 trials which are forthcoming or have been presented in the last 12 months in important congresses. So these are transplant ineligible patients. I've got somebody who's 75. I'm not even thinking that I should take this patient through a transplant. So, that whole question of is it or is it not an existential crisis doesn't really exist here. Anyway, so the Enrich trial it wasn't a late breaking abstract, but we like it because we have UK authors on it. So you've got some very similar, very familiar names, maybe not for you, but for me, Simon Rule, who works in Plymouth, who's done really well despite not being in London or Oxbridge, and Toby Eyre is an Oxbridge boy. So both of them have recruited a whole lot of patients in this particular trial. And the trial here is going, what is really, dare I say, sexy in hematology? Everybody wants to go chemo-free, right? Nobody wants patients to be prisoners of chemotherapy. So can I do a chemo-free regimen? So this is that enticing chemo-free regimen. So Enrich is basically a combination of rituximab and ibrutinib. So that is your experimental arm in Enrich trial, and that is compared to your standard of care. Standard of care in UK for people who are unfit are regimens like BR. We might modify the dose of bendamustine if the patient is too elderly, or just R-CHOP. So R-CHOP and R-bendamustine are our two go-to induction trials for transplant unfit patients in mantle cell lymphoma. So this is the randomization, and this is the take-home message. So this is your saffron line, and the saffron line here is the line of the chemo-free regimen, ibrutinib and rituximab, and this is the line of your standard chemoimmunotherapy. So here you've got patients who have had R-CHOP, or they have had R-bendamustine for induction. And here I can very easily, and there's a lot of wiggle room for my laser pointer, so you can tell that the hazard ratio is significant, the p-value is significant. It looks like when it comes to progression-free survival, rituximab ibrutinib is doing well. The same can't be said about overall survival. I don't have that slide perhaps, but there's a trend towards a better overall survival, but not statistically significant as yet. But there is certainly a PFS advantage, but it needs to pick up. The granularity in the data is as follows. So if you split the induction regimen as R-CHOP and R-bendamustine, you can see that the saffron line, which is your chemo-free regimen line, is significantly better when it comes to R-CHOP. But if you look at R-bendamustine, they're very close to each other. So for me and for many others, the take-home message from the Enrich trial is that R-bendamustine and ibrutinib rituximab probably have, or rather give your patients an equal PFS. Obviously, ibrutinib rituximab is going to be far better tolerated because it's chemo-free, unlike bendamustine rituximab. But with respect to efficacy, at least what you can say based on these curves is that the chemo-free regimen is non-inferior. It's not inferior to your bendamustine rituximab, but it is definitely far superior as opposed to R-CHOP. So those are our take-home messages. The last study is the ECO trial, and this was, I think the first private patient in London who basically had this regimen was at our institute. So, we feel a little bit like what the Americans did, we could do very quickly. This is, again, not licensed in the UK, but if your pocket is a little bit deeper, and this is in contrary to what I said in the beginning, you might be able to get a slightly better regimen. Anyway, so this is your standard of care for transplant ineligible. And as we told you, that bendamustine rituximab is our favorite regimen. So bendamustine rituximab followed by maintenance rituximab is our standard regimen. And basically what you're doing is you're putting in acalabrutinib on top of that. So this orange color here is your standard regimen without the acalabrutinib, whereas here you can see that acalabrutinib is continuous. And acalabrutinib continues beyond rituximab like it normally does for CLL. So it will continue till you have progressed or you've developed a toxicity, which you seldom develop on acalabrutinib. And you can again see that the take-home message is that the curves do separate out for progression-free survival. The hazard ratio is around 70-73%, which means there is a 27% reduction in death or progression if you can add acalabrutinib on top of your BR, both induction as well as maintenance. This was a trial which was done during COVID time, and therefore, if you look at the data and the curves, when you censor those for COVID deaths, because there was a significant amount of COVID deaths in both arms, you can see that the progression-free survival looks even better. So unlike the 27% that we spoke a nanosecond ago, you can see that the curves separate out by around a gap of 36%. So for COVID-censored death, acalabrutinib significantly is improving your PFS. Overall survival has not improved as yet, but watch the space is what I would say. So this is Michael Wang, who presented it a year ago in EHA. So this is not 2025, this is 2024. And again, he thinks that this should be the standard of care. We are hoping that this will be our Christmas gift in mantle cell lymphoma by NICE, and we are hoping that our carping so-called regulatory body might give us a permissive nod just before Christmas so that all NHS patients can also have acalabrutinib on top of BR. I think one of my colleagues recently got it via compassionate access. So sometimes if you can't do it in the private sector, I think if you beg and plead to the company, you might be able to get it as compassionate access on a patient named basis. Okay, this is another trial that Marsden is running. King's College isn't running it. So this is basically using zanubrutinib rather than acalabrutinib. I personally don't like this trial for the reason that like to like is not being compared. So if you look at the so-called standard of care arm after RB, there's no rituximab maintenance. That is not what you're doing, right? Whereas if you go in the Zanu arm, you do get Zanu till progression. So I'm not too sure how you're going to report the Mangrove trial, but I think that would be one of the major limitations of not having rituximab maintenance in your standard of care arms. Okay, I'm not going to do this. We're going to move on to our next sushi platter. I mean, I'm a big fan of Japanese food. And the reason why you're seeing a sushi platter is not because of that, but because the next few highlights that you're going to be seeing is like eating a short maki. We're not going to be talking about this for 15 minutes. We're just going to do a trial, a quick headline, and then we're going to move on. So this will roll really, really fast because I'm conscious of time. Okay, so this is about non-malignant hematology, just so that you move from the right to the left side of your cingulate gyrus. So hopefully everybody knows that we do have a reversal agent for our DOACs, and Dexanet is the decoy molecule that you're using to reverse DOACs. So when people come with bleeding, I don't know, severe gastrointestinal bleeding, life-threatening bleeding, intracranial bleeding, though it is not licensed for intracranial bleeding. I'll come to that in a minute. This is a decoy molecule. So andexanet is here. And andexanet looks very much like factor 10A. Therefore, all the apixaban, all the rivaroxaban in the patient's stream, in the bloodstream, which is causing that major hemorrhage or bleeding, life-threatening, is going to look at andexanet, and it's a decoy molecule, so it thinks, hey, you're factor 10. I'm going to stick to you and I'm going to inhibit you. But actually, andexanet has no catalytic domain at all, so it does not participate in meaningful coagulation at all. It is not factor 10A, right? And therefore, all that apixaban and rivaroxaban is just getting sapped by andexanet, and that is how it reverses it. For people who have used it, you've got to give a quick bolus, and then you've got to follow it by a 2-hour infusion as well. It came from the Annexa 4 trial. But the license currently is not for edoxaban. So we can use it for, I mean, you can extrapolate it, but at least in the UK, you will go by strict trial criteria. So apixaban and rivaroxaban are the only two agents where this is being used as an antidote, because edoxaban was not a part of the trial. And with intracranial hemorrhage, we are not using it because the risk of thrombosis and death was 10 and 14% respectively, or maybe the other way around. But people are tempered by 1 in 10 deaths, or 14% of repeat thrombosis and so on. So there is a little bit of tempering to that. The molecule is 19,000 pounds, even in the NHS and UK. So it is an expensive reversal agent, unlike PCC. So what we're going to talk about is something that was presented just 8 or 9 months ago. And this is not a late-breaking abstract, but everybody is talking about it because there might be a new reversal agent for DOACs. And this slide is just telling you and scoping how big the problem is. So all over the world, there are 25 million people who are probably needing some form of anti-10A inhibitors. Apixaban is our favorite one, and I'll tell you why again in a minute. But rivaroxaban, edoxaban, maybe even Dabi, but dabigatran has a different reversal agent. As you know, it's called Praxiband. And out of those, over 1 million patients will come to emergency care because there is bleeding. 2 to 3% of people will also need surgeries very urgently, and therefore reversal of agent is important. So these are the two current things that you've got. You can either use Octaplex or Beriplex, which is here, which is factors. You're basically giving factors 2, 7, 9, 10. It came as a warfarin reversal agent, but people extrapolate and say, apart from 2, 7, and 9, there's also 10 in beriplex. And therefore, if I'm giving an anti-10A inhibitor and giving them more 10, then maybe there will be some reversal. In my small experience, I think it works reasonably well, and we use it for intracranial hemorrhages since andexanet doesn't have a license. But these are not perfect reversal agents because they are not for all DOACs. There is a scare of rebound thrombosis. There is mortality associated, etc., etc. So this is something which is trending. This is a molecule which is called as VMXC001. I'm just going to call it VMX. And I think the beauty about this is that once they presented their animal model and their liver injury data and their human volunteer phase 1 data, people were so impressed with this molecule. And mark my words, there is no phase 2 trial for this molecule. It's going directly into phase 3 because it comes with a lot of promise. And therefore, I think this might be more hope and less hype. And therefore, I have curated it for this particular highlight session. This is something where you have to go back to the Australian brown snake. When you talk about clotting and DRVVTs and whatever, the snakes and venoms are very important. So basically, this is a chimera which is derived from the so-called 10A molecule, which is present in the venom of this Australian brown snake. So for people who are not familiar, I'm just going to walk you through this slowly. So basically, if you look at the liver, as in the factor 10, which is produced by the human liver or even the snake liver, once you start giving apixaban, you can see that 10A is inhibited quite significantly, and that's how apixaban is working. It's an anti-10A inhibitor. But this particular venom 10A seems to be intrepid. It seems to be indestructible. It says, whatever apixaban you want to throw at me, I won't get inhibited. Can you see that? Apixaban concentration, more than 100-fold. You can see that 10A is like your skyscraper in Mumbai. It's on floor number 74, right? It's not going down. So this is unassailable, and this is saying, whatever you want to throw at me, I am indestructible. So when scientists and people who are geeky like Sheldon looked at the structure, they figured out that the difference between the 10A molecule in the venom and the liver was predominantly in this particular loop, which is called as 99 loop. There's a difference of 16 amino acids. And it's this 16 amino acids in that so-called binding catalytic site, which is the 99 loop site, is what is giving the so-called power, almost Putin-like, to this particular venom 10A. So then people basically derived a recombinant chimera which had a similar sequence. They manipulated the 99P loop with those 16 amino acids and made VMXC001. So VMXC001 is a chimera of the venom 10A, which is indestructible by apixaban. That is the take-home message. So that is the science and sounds convincing. Let's see how it translates very quickly. So this has a very high IC50, and this also works really, really well with high levels of apixaban. So what I want you to take home is that this is actually not a reversal agent. This is a bypassing agent. So this is your clotting cascade. This is your common pathway where the 10 is converting from, producing a lot of thrombin burst. And this is your extrinsic coagulation factor, which is tissue factor and 7, which is feeding into this. What apixaban is basically doing is that it is just not destroying, but it is inhibiting or scuppering the interaction between the tissue factor 7 and the factor 10 tenase complex. And that's how it's inhibiting 10A, and therefore there is no thrombin. Can you see that? There is no thrombin. So if I have a patient who is bleeding or who requires urgent surgery and has swallowed apixaban 90 minutes ago, which means the levels of apixaban are there, as in like really high in the blood, then how do I get rid of that apixaban? I don't need to use andexanet in this case. I can use this venom 99P VMXC001 molecule because that is a bypassing agent. So it doesn't really care what's happening at this part of the cascade. This is going to work independently of apixaban, rivaroxaban, edoxaban, and it's going to generate thrombin. So this is bypassing that particular part of the cascade and generating thrombin. Because finally, how are you going to prevent bleeding? you want to produce a clot, right? It has to stop bleeding. You need thrombin, thrombin, thrombin. And here is your thrombin burst, which is given from the venom chimera recombinant molecule. And this is a little bit geeky, but I'm just going to spend 30 seconds on this because this is their phase 1 data. So these are apixaban levels, which are therapeutic. And this is where the thrombin generation should be, okay? So don't look at these three things right now. Imagine, I should have put a slide which didn't have these three boxes. But anyway, so this is where your thrombin generation should be. This is what you need to adequately generate to prevent hemorrhage and so on. So what you can see is that when people are getting this molecule gets your thrombin generation within normal ranges. How does it compare at the bedside to something like andexanet? The problem with andexanet is it actually overshoots, and maybe it's a speculation, it's conjecture. I don't know whether it's 100% true, but likely to be true. You can see that the reason why 14% of people are presenting with rebound thrombosis is because it's overshooting. Because once you give people andexanet, and it's a little bit cumbersome, it's quite expensive, bolus followed by 2-hour infusion, etc., you can see that andexanet is punching above, it's producing supraphysiological thrombin, and therefore might be prothrombotic. And PCC is nowhere. I mean, PCC is not really doing anything to the thrombin. So God knows how it's working, but it's working. I think this is kind of providing you the science behind it. And the last bit is, I think there is a model which is the liver injury bleeding model with rivaroxaban. This is from monkey models, and don't really stab and go for my jugular, because this is now also gone through phase 1 in humans. I think there are 78 patients, not patients, volunteers who have had this with no inadvertent toxicities. So what you can see here is that this is the bleeding time in somebody who's got rivaroxaban in that so-called monkey liver bleeding model. And you can see that in these 2 doses of VMX molecule which are being tried, the bleeding time becomes significantly lower, telling you that it works at the bench and will work at the bedside. This is your PTs and DRBBTs, and you can see that with varying concentrations of VMX, you kind of normalize the PT, and these are 4 different concentrations of VMX, and at all concentrations, you can see normalization of your prothrombin time and DRBBT, which, as you know, is also super sensitive to all your DOACs, right? So it looks like it's working, and the phase 3 trial is actively recruiting. If I'm not wrong, it's called Equilibrix X or something. We are trying very hard to open this at King's College Hospital. We have gone through the initial phases, and we are hoping that maybe in the first quarter of 2026, we will have BMXC001 on the Denmark Hill campus at King's College. Who knows? I mean, I'm hoping so. But yeah, so this looks like a very promising molecule. Look at the half-life of that, going up to almost 30 hours. So once you get, and apparently it can go over 10 to 15 seconds. So it's like a really quick bolus, unlike andexanet. And it does really, kind of generate that thrombin for a good period of 24 to 30 hours. So the trial that we are hoping, the arm of the trial that we are hoping to open up is the surgical arm. So people who are going for emergency surgery when they are on apixaban, edoxaban, or rivaroxaban. And on that note, we're going to continue with this. Let's see, 40 minutes. So I started at 6:10. Okay, another 3 or 5 minutes and then I'll stop. So we're going to move on to 2 important trials, which are also in the world of hemostasis and thrombosis. So this is something which was presented in ASH last year. This is the RENOVE trial. And for me, it is very affirming. So in the NHS, I offer 2 clinics, which means I roughly see around 40 patients a week, which might be significantly lower than what you see. But out of those, I think in every clinic, I'll have 2 or 3 patients where, I'll have to have that really horrible discussion of, should you stop your rivaroxaban or should you continue lifelong? Is it unprovoked? Is it provoked? So this is a good trial which affirms these decision-making in my so-called due to stop clinic. So for us, it's quite important that this trial came through. So the premise of this trial is that so don't read this, it's very wordy. If you can just listen to what I have to say for the next 60 seconds. I mean, I don't know how you're doing it. I'm sure you're doing it the same way as we are, is that if somebody's got an unprovoked VTE, if somebody's got unprovoked PE or unprovoked DVT, there are no provoking factors, persistent or transient, then we are very nervous that the risk of recurrence is around 8 to 10% per year. We roughly believe that over a period of 20 years after that event in unprovoked category, there's a 40% chance of recurrence. That's the goalpost or rough approximate figure that we are giving our patients. So if I had a PE in January, and now it's November or October, and it's time for me to say, it's closer to a year. Should I just stop my apixaban now, or should I continue? I will continue, because if my PE was unprovoked and not because of a surgery or long haul flight or whatever, then my recurrence is around 20% in the next, is around 40% in the next 20 years. I do not want to take that risk, so I will continue on apixaban lifelong. I will not put a clock on this. There is no end date to that. So the question is that once you complete 6 months, 12 months, or whatever, can I reduce the apixaban from 5 milligram BD to 2.5 milligram BD? Can I reduce my rivaroxaban from 20 milligram to 10 milligram? And maybe you are already doing that in your clinic, but please remember, if you look at this, you are extrapolating data from these two seminal trials, Einstein Choice and Amplify Extend. But these trials are not empowered to answer that question of reducing the DOAC by around 50% after the first 6 to 12 months. The comparator arm is either a placebo or aspirin. If you really want to do a proper trial, what should you do in the unprovoked category? At the end of 12 months, after I get an unprovoked PE, half of me, as in half of the patients, will go on the full dose of apixaban, continue it, 5 milligram BD, and the remaining will go on 2.5 milligram BD, and I need to compare those two arms. And that is exactly what this trial has done. So it's a first in the class trial, which has actually provided you with evidence prospectively in a randomized fashion, telling you if I reduce the dose of rivaroxaban and apixaban to half, then what happens? What happens to my recurrence? What happens to my bleeding score? That is what it's doing. So this is being presented, I think, by Francis Coutreau, who's from France. So this, you could argue that it's only a French trial, but there are more than 2,000 patients in this trial, which is a big number, and they are from 47 different centers all over France, okay? So this is the take-home message. So this is what they're doing. So if you have somebody with unprovoked and therefore they are at a high rate of recurrence, can I reduce this? Or should I continue on full doses? And the follow-up data that you will see is for 2 years. So this is something which uses the probe design by a hierarchy statistical model. And we're not going to dwell on that because I myself don't understand the statistics very well. But for sake of time, I'm just going to show you the important curves, okay? So the numbers, I mean, hopefully Amit will be able to give you these slides, or Kalpesh will be able to give you these slides. I'm happy for this slide deck to be shared with delegates if they're interested. But this is what you're looking at. So what we're looking at here is the estimated risk of recurrence. And you can see that it is not statistically significant between the low dose and the full dose arm, which means that even if I was to reduce my apixaban by half or rivaroxaban by half, my risk of recurrence is very similar to when I had the whole high dose. But this is the most enticing part of the trial. This is the bleeding risk, right? Because you're worried about if I'm unnecessarily going to swallow 10 milligrams or 2.5 milligram BD of apixaban, am I unnecessarily exposing myself to the risk of bleeding, right? And therefore, if I reduce it, my risk of bleeding will go down. And here, these are the graphs which are showing you that. So if you look at the so-called clinically significant or major bleeding and non-major but clinically significant bleeding, the curves do separate out very well, telling you that the blue curve wins, right? Because here you want the curve to be saggy. You want your risk of bleeding to be lower. So you can see two saggy curves with the blue line telling you that the blue line is perhaps as good as the red line when it comes to preventing recurrence, but at the same time, it is much safer because it's reducing the risk of hemorrhage or reducing the risk of bleeding. So that is the take-home message. So based on this, we remain very confident. So when we have discussions with all these patients in the clinic, both in the NHS and the private sector, we'll be saying to people, based on these trials, we remain confident that after a year or whatever time, if you want to reduce your dose of apixaban, you can do so. However, there are always exceptions to the there's granularity of data. So the only two things or three things that I'm going to tell you is that if you have somebody who's pleasantly plump, so this is the subgroup analysis of the trial. So if somebody's got a high BMI, upwards of 30 kilogram per meter squared, you know the DOACs have a license now now. We allow DOACs to be taken now. At least in UK, we will be permissive up to 50 kilogram per meter squared. Before that, it was 40, and we were doing levels. That is not the case now. But anyways, so if you're pleasantly plump, then it looks like maybe you shouldn't really reduce that dose by half, whether it's apixaban or rivaroxaban. So if I have a patient who's above 120 kilos or whatever, I might be saying, hey, maybe you should continue with the same dose. And then the other thing is that if somebody presents with PE, which is pretty high risk, and typically I would say if you required thrombolysis, I mean, I'm just generalizing, but if your PE was so bad that you required thrombolysis, or at least people thought that you would require thrombolysis because it was high intermediate on the PESI score, then I think we would say that the clot burden might be substantial, and therefore you don't want to take the risk. So those are two caveats where we might actually say, then don't do it. But otherwise, we're very happy for doing that. The last one that I'm going to do, Amit, and then I will stop, is the ISTH Congress, which was in Washington, D.C., June, I think, or July of this year. So there is this big trial, which is called as COBRA with a double R. And this trial is, I mean, many people have retrospectively compared apixaban and rivaroxaban. The companies are very reluctant to let them go head to head. But there was an increasing signal that apixaban was a better DOAC than rivaroxaban when it came to the risk of bleeding. And meta-analysis have indicated that, but we never really had a prospective trial. So I don't know how the companies have allowed this to happen, but it has happened. So I think it's quite historic. And needless to say, it's a late-breaking abstract in the ISTH Congress of this year. So here you're basically looking at patients with an acute event, whether it is a DVT or whether it's a PE in the first 3 months, and you're comparing apixaban with rivaroxaban, and you're looking at what is the risk of recurrence, what is the risk of bleeding. And I think, it doesn't take an Archimedics to guess what the results would be, because we almost second guessed it from retrospective studies and meta-analysis. Here is the take-home slide. So what it's telling you is whether you use apixaban or rivaroxaban, but please remember, this is just the first 3 months. So this is acute VTE. That is a disclaimer here. We don't know what's happening long-term. Probably the same, but that's an educated guess. It's not evidence-based. But at least in the first 3 months post-VTE, what you can tell is whether you use apixaban or rivaroxaban, the risk of recurrence or clot propagation is the same. But here is the big difference. So with apixaban, people are getting less bleeding. And I think the risk of clinically relevant non-major bleeding is 7% in the rivaroxaban arm, and it's 3% in the apixaban arm. And therefore, it is statistically significant with a good p-value. So for us, our go-to agent predominantly now, at least in the UK, fed by the recent COBRA trial, particularly for people that we are worried are going to bleed. So if I've got an 82-year-old woman who basically has an EGFR, which is like 45, 60, and I'm worried about bleeding risk, I'm obviously going to put apixaban. And now I can say with confidence that this is not just retrospective and meta-analysis, but this is a prospective trial, which is telling me to do so. Okay, so that is the COBRA trial. So on that note, I'm going to stop. So Amit, I'm going to try and see whether I can stop sharing. Yeah.
Fantastic, sir. As always, very, very good to listen to you. And what an update. Just opened my eyes. I think all our eyes has also opened up. Beautiful. No words for it, sir.
Gosh, you flatter me. Go on, Amit.
Thank you so much, sir. And I request now all our discussants to please put the hand raise sign so that we can start our question answer session. In the meanwhile, let's take some questions from the audience.
Yeah, so I can read the first one. Okay, so you moderate it. So
Dr. Karthik has a question. For high MIPI or high Ki-67, autologous stem cell transplant outperformed ibrutinib. Is it right?
with ibrutinib. So basically, you're absolutely right, Karthik. What the trial showed is that if you have somebody with a high Ki-67, upwards of 50%, then you should do autologous stem cell transplant. But when you're doing autologous stem cell transplant, you still have to maintain the ibrutinib, by which I mean that in that induction, you're giving ibrutinib, then autologous stem cell transplant, and with rituximab maintenance, you're still giving ibrutinib. So it still contains ibrutinib with autologous stem cell transplant, but discontinuing that is not a good idea in people with high Ki-67. Yeah.
True, sir. Another question is again from Dr. Karthik. for TP53 mutated mantle cell lymphoma? What is your practical experience?
Very bad. So yes, it remains an unmet need, just like AML. So in CLL, P53 doesn't bother us so much because second generation BTKIs do well. But in mantle cell lymphoma chemotherapy, if you go to ASH and Lugano, some people will also provocatively say, why should I subject my people to chemotherapy? It's not really working because their survival curves are very poor. So in the last 3 to 4 months, every time we have had a P53, we have done something provocative. We have done what the Bovin trial does. So Bovin is a trial which is a phase 2 trial, and basically is typically for high-risk mantle cell lymphoma patients who are P53 mutated, and they use a triplet combination. It's a phase 2 trial, so there's no randomization. So it uses a combination of B, O, and V. So basically, you're basically using obinutuzumab, and you're also using venetoclax in there, along with bendamustine. And then basically if you look at the P, and I did have that slide, but we didn't have time to talk about it. If you look at the progression-free survival at 2 years, it's around 75%. I'll take that for P53 because for me, that is a good PFS for 2 years. So though it's phase 2 data, we are quite sobered by our chemotherapy not doing well. So we have typically done the Bovin protocol, begged to companies and got it on compassionate basis. Yeah, triplet regimen.
Thank you, sir. Another question Dr. Karthik has is, will you do repeated imaging for unprovoked DVT if at 6 months imaging has shown partial clot?
We do not do repeat imaging. I don't think there's a lot of evidence for that. The only time we will do repeat imaging for unprovoked PEs is a few exceptions. So if, for example, the patient is still breathless or still has respiratory symptoms, their exercise tolerance is really reduced, we will do that along with an echocardiogram. And it's not so much for residual thrombosis, it's more to make sure that they've not developed pulmonary hypertension. So we will do a CTPA and followed by an echocardiogram, put them in the cardiology or pulmonary clinics to make sure there's no residual pulmonary hypertension. Sometimes I will do a repeat scan in patients with PE who are unprovoked, though it's not my norm, if there is cancer-associated PE, because these are very, very thrombotic patients, and you worry that the clot burden might still be substantial. So the answer is that there are only a few exceptions when at least I or we will do it. We wouldn't do it for everybody. But if there were symptoms which were persistent for ruling out pulmonary hypertension, or in very thrombotic patients like cancer-associated VTE, we will do them. Otherwise, we wouldn't.
Thank you, sir. Another question from Dr. Akanksha. For blastoid variant of mantle cell lymphoma, who is 65 years old, what induction regimen would you offer?
So it depends on whether the patient is chronologically or biologically 65. If she's a fit, or if he's a fit 65-year-old who's going to the golf course, doing aerobics, still working, and really good performance status, I will do the Nordic protocol. So we can't use, I mean, unless he's got a private insurance. So we would do a Nordic protocol. And then put him on maintain. We can't follow the triangle because the Nordic was not a part of the triangle. So I would still, in the NHS currently, I would still do Nordic followed by autologous stem cell transplant followed by rituximab. If he had a private insurance, or I could swing one way or the other, I would still triangle him. So that is for a fit 65-year-old. But if the patient was unfit, then my go-to regimen will be echo. So if he was, let's say he had hypertension, diabetes, gets out of the house but doesn't really get to the golf course, so you're kind of slightly unfit, then I will do bendamustine rituximab with acalabrutinib. So I'll go for the echo.
Thank you, sir. Dr. Gopinathan, your question.
Good morning, sir. That was really a lovely update. My question is quite simple and straightforward. Role of rituximab maintenance after a BR induction in transplant, elderly unfit individuals.
Yes, we still do it, is the short answer. But I think there's always something called precision medicine, and then there's personalized medicine. And that's why you have MDTs, right? Because you are trying to blend precision medicine with personalized medicine. So if your patient is really unfit, in my mind, I think rituximab is very well tolerated. It's not like obinutuzumab. In our experience, obinutuzumab is a more potent antibody, leads people with more infections, more immunosuppression. But for us, rituximab is pretty straightforward. So I would be very favorably inclined towards considering that maintenance. There certainly is a role for our maintenance even if your patient is terribly frail and doesn't, I mean, I don't know how you're doing it, but for us, rituximab maintenance is 1400 milligrams subcutaneous injection, right? Every 2 months, they get a subcutaneous injection, 5 minutes it takes, 1400 milligrams, you're done. So for us, we will still do it. But if you've not done it, so for example, if you're, the guidance of the British Society of Hematology says that if you've given somebody R-CHOP or BR, then you do that maintenance, and that's a 2B evidence, or maybe even 1A, maybe 2B. But I think if you're giving somebody a regimen called RBAC, so we didn't talk about RBAC, it's very popular in Plymouth, not in London. So this is R-bendamustine along with a little bit of cytarabine, so it's RBAC. Our guideline says that if somebody has had induction with RBAC, you do not do rituximab maintenance. But if you've got R-CHOP and if you've got BR, we will push for rituximab maintenance for the reasons I alluded to.
Right. Then second thing is right now almost ibrutinib is out of the market currently. So can we all equate that acalabrutinib will replace the same whatever the trials are talking about?
Yes, I think it's already replaced. In the ECO trial, we are using acalabrutinib for the transplant unfit patients. So you're still using acalabrutinib. For us, I think the zanubrutinib trial has not really recruited completely and presented. So you could extrapolate and use it, but it will be evidence-free. The place where we are using zanubrutinib is first progression. So if I have, in fact, I just had one on Friday. So I've got this fittish 68-year-old patient that I gave BR to, and he was on rituximab maintenance. And after the second or third rituximab maintenance came with cervical lymphadenopathy again. So clearly he's now going for CAR T cells. We will be using lysocell, not brexucell. But the bridging is important. And in that, we have started using zanubrutinib there. So your speculation is absolutely right. I think ibrutinib is very passe. People are worried about cardiac toxicities. So yes, second generation BTKIs will take over. But if you want to practice evidence-based medicine, then the current evidence for first line is only acalabrutinib, and for second line, zanubrutinib does have evidence. Yeah.
Your last question maybe, sir. Current practice for DOAC-induced bleeds. What is your current practice? And we don't have really access to this novel agents. So what's your current practice for DOAC-induced bleeds?
So I think I get a lot of these questions, and I think sometimes you have to grill your junior doctors. So the first thing is that there are 2 or 3 important questions. If somebody is bleeding on a DOAC, you have to answer 3 questions. Number one, when did they last take the DOAC? So apixaban, one half-life is going to be over within 12 hours. So after 2 half-lives, there'll be no apixaban. So if somebody's taken apixaban, say right now the time here is 7 o'clock in the morning, right? If somebody's taken apixaban 7 o'clock last night, there's hardly any apixaban in his body. So there's nothing to reverse. So timing is important. Number 2 is what is their renal and liver function test looking like? So if somebody comes with an eGFR of 30, then they're going to take much longer to excrete apixaban. So you have to kind of try and map where the Cmax of the drug would be. And I sometimes will say to people that if you're at the tail end, then there's no need to reverse. Give some tranexamic acid and do whatever it takes to stop the bleeding. If it's a GI bleed, get your endoscopist, etc. But if somebody comes within 3 hours and comes with a big bleed, where they have activated a major hemorrhage protocol, then I will use either PCC or andexanet. I will use PCC for intracranial bleeds because that's the only license and it's cheaper for us. But if there's a big GI, so if somebody's taken rivaroxaban 20 milligrams at 5 o'clock in the morning and 7 o'clock they've come with a blood pressure of 60 because they've bled and poured 3 liters out, then yes, I will use andexanet. So PCC and andexanet. BMX-C001 is, very experimental.
Thank you.
Thank you, Dr. Gopinath. So anybody has any other question? Well, so in that case, sir, once again, a big thanks to you. You're a wonderful, wonderful teacher. Whatever you say directly goes to our brain, directly. So no words about every words are so crystal clear and so fascinating. The way you talk, the way you speak is marvelous. Thank you so much once again. And you are a great teacher. Just, sir, please.
Yeah, my ambition is to get the same award as MB Agarwal. What was it? Dronacharya. So tell Dr. MB Agarwal I might be competing. I'm joking.
Thank you, sir. Thank you so much.
Take care. Bye now.
Bye. Thank you.